Thank you so much, Dr. Durhane, for joining us. We are really happy to have you here with us today.
Well, it's been my real pleasure and privilege to associate with, your university, your students, and the work that you're doing. So I think this is a great opportunity and appreciate you inviting me.
That's wonderful. So to start, can we hear a bit about your background and your role in rare disease community?
Certainly. I mean, I have two children, both of whom were born with rare diseases, but that really wasn't what got me into doing advocacy for rare diseases. I got involved with a colleague whose son had hemophilia, and he got an HIV and later hepatitis. So I came in to help that community to actually advocate for changes to the access to treatments, to have improvements in terms of the whole blood system itself, and getting kind of compensation for these people affected. So it became a really almost a 7-year volunteer engagement with them that really got me, I think, understanding how important it was to do advocacy, but how valuable it was in terms of being able to affect changes. We saw huge changes that came through. So that was what kind of got me started. Before that, I'd been full-time as a professor of psychology at the University in Windsor, and decided that I really would prefer to do much more hands-on work, and sort of came full-time into being a patient advocate.
That's wonderful and so kind of you to advocate for rare disease community. I myself have listened to a lot of speech you've done. They are absolutely amazing. As the CEO of Canadian Organization for Rare Disease Disorders, can you tell us about the experience of rare disease community during the COVID-19?
In Canada, as in many communities across the globe, and not just for rare diseases, of course, COVID-19, first of all, was a huge impact on the community, and those patients who actually had diseases that were highly susceptible to things like lung infections or other kinds of comorbidities were very severely impacted. But also for everybody, we saw that patients could not get into the hospital, get diagnosis, they couldn't get testing, they couldn't get access to treatments. Even things like blood transfusions for those patients who were on regular transfusions were severely impacted because of the hospitals. The people had to go in for infusions and other treatments. A lot of those, ended up being delayed, but most important, of course, was getting access to the ongoing testing. But rehab, we found that patients who regularly depend on rehab for services, those again were not available. Over that long period of time, unfortunately, it was a long period of time, people began to adapt. Healthcare professionals learned how to do rehab sessions over Zoom. They need to train the parents how to do it. They did speech therapy over Zoom. We had, nurses' aides who came out to homes to give infusions where necessary. We set up practice so people could go in and get secure infusions. So that took time. But obviously it was an impact, and we fear for many of the patients. Some of them certainly lost, a considerable amount of time, advances in terms of their treatment, but also suffered, severe impact in terms of their disease progression during that period of time. So yes, it was a huge impact. And the sad thing was, it didn't have to be that bad. It was just that I think everybody kind of thought it'd be over quickly. So, okay, we'll get over a month or two and we'll be able to get back to normal. And then when it became clear that it was not, we didn't actually put in other kinds of programs that really would be able to pick up on people. And I think that certainly is a huge lesson learned, is that you need to have, contingency plans. You need to have other opportunities and services for people in order to make sure that they're going to be treated. I can't say, Shane, that we've actually learned from that and we have those contingencies in place. I don't actually see them, but I think that's what we need to fight for. So unfortunately, we have not really, I think, learned the lesson and put in those kinds of ameliorating programs, but we need to.
Yes, I 100% agree. There is so much change and it took time to really adapt to the situation. And from reading the news, it seems like the impact of COVID-19 is still very strong on the healthcare system. There is so much strain, so much burnout. I think people just don't have the time to really sit down and think about a plan. That's certainly a lot of struggle. From my personal view is that we need to have the preparedness in the future when we overcome the strain right now, and really have that plan prepared before anything like this happen again. Thank you so much for sharing that. And I am aware of these past COVID changes in terms of health policy. COVID-19 did push some changes in the Canadian health policy in the past years. And could you tell us a little bit about that?
It changes in terms of policy, and also our call to the governments and the health systems, right, to actually adopt some of those changes for other chronic diseases, but certainly for rare diseases, I think has been a hugely important, set of lessons. I mean, what we saw obviously was the ability to actually bypass some of the strict, regulatory controls over getting access to medicines much more quickly, being able to put into place diagnosis centers to make sure that people at risk got identified, they got diagnosed, and they got referred. I think we saw in place also was the ability to get much broader public education and awareness so that people would understand kind of what it was that was, the potential risk and what they could do. All of those things, as we say, are hugely important when you think about rare diseases. One of our research documents indicates that, a child dies of a rare disease. I used to think it was sooner than that, but a child dies of a rare disease in Canada every 39 minutes. mean, that's a huge impact when you think about it. If it were saying that the child died of an infectious disease every 39 minutes, we'd be in a panic. If we say they died of cancer every 39 minutes, we would actually be rushing in because we recognize these are urgent situations. And yet we are not doing anything for lots of reasons in terms of the inability to really know how to address it. But it is a crisis situation when you think about it. So hopefully one of the things we learn in the rare disease community is how do you bring these issues and these diseases more to the center to raise the urgency of it and to also have strategies that could intervene. I mean, if we put the amount of research and development into rare diseases that we did when we poured it all into COVID, we certainly would be a lot further along in terms of being able to diagnose, in terms of being able to treat. But the other thing that we could do much better is actually taking the diagnosis that we have, like newborn screening, take the genetic genomic testing, which we use in COVID to actually identify many different strains of COVID, right? So all these variants that come up are done on the basis of genetic genomic testing. We have those for rare diseases, and yet we're not using them to actually diagnose and to be able to identify and to be able to track what's happening in the disease. We could do all those things, and I think those are the kind of things we should be calling for. And the same in terms of, if you think about cancer or heart disease or and COVID, just because we don't diagnose and we don't treat doesn't mean that we're not suffering huge expenses and costs to the patients in terms of real pain and suffering costs, but also to the system. So that should be an important lesson. If we diagnose timely, if we intervene, if we do preventive kinds of strategies, we actually will save lives and we will save actually costs down the road. So how do we kind of shift that equation a bit so that we are able to put in the money up front? That's what we need to do. So the lessons from COVID are really important to us, as long as we can recognize that rare diseases, as in many other chronic diseases, are just as urgent as something like COVID, which comes in as an unknown, virus.
Yes, that's very true. I agree completely. The amount of people suffering from rare disease together is a large amount of people, and a huge amount of them are actually children. It is a very sad thing, and we should always reflect on that and come up with new strategies to help. And with the genetic sequencing technique nowadays, there is a new hope, I think. And in our previous podcast episode, we invited a genetic counselor, Matthew Osmond. So he talked about using genetic sequencing and implementing match exchange program that match genetic changes with people with rare disease that lack diagnosis. So that's very interesting, and I'm excited to see more and more countries and places using that technique to help rare disease patients. For the next question, I'd like to shift the gear and ask you about the Rare Disease International that you mentioned in other talks. Can you tell us a little bit about that?
Sure. Rare Disease International, so CORD, Canadian Organization for Rare Disorders, is a network of patient organizations in Canada, 100 or so groups. Rare Diseases International is a global alliance of national groups like CORD, or like NORD in the US, or like EURORDIS across Europe, and also international disease groups. So hemophilia, muscular dystrophy, other diseases that have international societies. So our goal is to work on global issues and work with global organizations. So for instance, we have a memorandum of understanding, meaning we partner with the WHO on certain key projects that we've identified together. We had last year, working across a number of groups, been able to get the United Nations to make a declaration on rare diseases, which is hugely important because it recognizes rare diseases is not just a medical issue, clinical issue, but also a social issue, an economic issue, an inequity issue, and an educational issue. So it allows us to be able to push for resources, through countries to be able to address the wide spectrum of impact of rare diseases. So we work at the global level, and there are lots of things we do at a policy level that we hope, would be able to help groups that are working at national levels or even below the national levels, right, to be able to call on those policies, to be able to access, services, to call for changes. We had just recently a side meeting with the Office of Human Rights, and looking at gender issues and recognizing that rare diseases, like many diseases, has an inordinate impact on females, so women as caregivers, oftentimes as carriers of diseases, but also, the inequity in terms of diagnosis, even in terms of diseases, where men and women are affected. A lot of times the woman has a much harder time to get the diagnosis than the male does. So these are the things that we're calling forth in terms of recognizing, at a global level, international level, and making sure that patients recognize that they can call for these as a right in terms of getting better equity on these many issues. So we work at the global level. We try to work with our national alliances to provide them with skills and training so that they can do a better job in terms of developing plans, working with their health systems, working with their governments, but also then working with their member organizations that could be disease specific in their own environment. So it's a pillow effect that I think certainly has helped us in Canada being able to call upon some of the policies like the centers of excellence that are looked at a global level to say, okay, can we take that model, implement them in Canada as well?
That's amazing. It's very interesting, and it really breaks my heart to hear that. The inequality within the diagnosis and all kinds of other aspects. It really reminds me that a disease, a pathology, is not just waiting for treatments. It is happening to a human, and we have to look at it in a holistic way. And it really affects a person's life from all kinds of them.
Actually, you mentioned something very important that I had not really kind of come back to, and that is one of the things that Rare Disease International is doing, and one of our missions is on equity across economic and cultural regions. So, I mean, as much as we struggle, right, in Canada and in other developed countries, the impact and the lack of access to diagnosis or treatment in lower income countries, in countries with emerging healthcare systems, in countries where there's some real cultural biases, where rare diseases is a stigma and they cannot actually be able to be, diagnosed or enjoy the same kind of rights. It's important for us at an international level to also help to ensure that there are, patient organizations, there are healthcare systems, there are governments that are paying attention and able to make those kinds of adjustments. So speaking at the global level, we can call upon other countries. Speaking of regionals, we can call upon countries to look at what their neighbors are doing and really try to raise the level of attention and support for rare disease globally. So yes, I think that was important that you're talking about in terms of the equity there, because equity does exist, inequity exists right across the globe, and certainly a lot more so when we're looking at countries that are very much, oppressed in terms of either politics or economics, or in terms of access to, other resources, expertise.
Yeah, thank you so much for bringing that into the topic, and I just want to thank you so much for so many years bringing the awareness and educating people everywhere. It's amazing work that you're doing, and it really inspired me to also wanting to help, and hopefully more and more people are aware of rare disease, and that would bring a positive change to community as a whole in the world. So knowing that you are initiating this global endeavor, what do you think are some of the challenges that might be resolved through this initiation, and what are some challenges that still remains?
Well, sadly, the challenges that remain are so much larger than the challenges that we've been able to resolve. The outstanding issues that we've got are so much greater than the successes we've had. But we build on the successes, and I think that's what's important, right? What we have seen is, for instance, countries that have adopted national plans. Malaysia has a national plan for rare diseases. Philippines has a national plan for rare diseases. They're putting funding for the Philippines, for instance, in newborn screening, creating a network of screening that can reach right across the many thousands of islands that they have, and agreeing that when they actually have patients that are diagnosed, they can provide treatment. That's a huge step forward. It may seem small, but it's major, right? In terms of the investment there, and investing in genetic counselors. When we see in Malaysia, the ability to bring together the many patient organizations, number one, to work singularly, but also then to get the government, right, to begin to put in policies and programs in place. Those are the kind of things that we see in many countries that had not existed before, and really work because they were working more collectively. I think that's the important thing. We've also seen, of course, major areas of expansion in terms of the kinds of drugs that are available. That's been hugely important. And one of the things that works for us in terms of the global community is getting more people into clinical trials, getting more countries that are not yet represented to actually be able to be represented, not just in the clinical trials, but encouraging, companies that are developing drugs to actually set up centers of excellence and set up, treatment sites, and to invest in the resources. Because it isn't just bringing in a drug, it's bringing in the diagnosis, bringing in clinicians that can get training, bringing in the other kinds of supplies in order to make it so that these drugs are not only going to be available, but actually are going to be effective. That's been good, in the sense that we've gotten more therapies and more companies then, and that are working collaboratively, oftentimes with governments. We're pushing for these public-private partnerships to allow governments to partner with private companies to be able to set these up on a go-forward basis. And I think those have been, really valuable. And again, as I said, the more we've got the international community involved, international drug companies and international kind of coalitions like the regulatory groups, agencies that come together, the faster we'll be able to advance, but also the wider the spread in terms of where those benefits are. So I think we're seeing, newborn screening. There's a new initiative that's going to look at newborn screening globally, and hopefully begin to come forth with some guidelines in terms of what are the essential, tests that should be available in all countries. The more we've got countries involved, hopefully the cheaper these can be, the more expertise there will be. Last year, we published a list of what we call the essential medicines for rare diseases, and we've been working with the WHO and others to try to get countries to acknowledge them, doing an inventory and see how many of these drugs are actually available, but also looking at what are the barriers. Because some of these drugs, are cheap. They're old generic drugs. They're absolutely commonly available medicines, but they're not being made available to the patients. So we need to understand what are the barriers there. Is it because they aren't getting diagnosed? Is it because there's no specialists there? Is it because there are regulatory barriers to keep these drugs from being able to be made available because there's, not the expertise to review them and to monitor them, or Even though we think of them as cheap, maybe they're not cheap. If you're talking about a healthcare system that's just emerging and is besieged with all kinds of other kinds of challenges, right? So, and are there solutions then? Are there better collaborative solutions that we can have that would allow us to be able to provide, much more global access to diagnosis and treatment? Are there sample programs that we can make available that on everything from, care, and some of it is care and management, but also mental health and wellness, and family care. I mean, there's some amazing programs that are in place. I just came back from Sweden at one of the premier, family sites for rare diseases, where they bring in the whole family and they bring in the children. Those are the kind of things that could actually be implemented everywhere. Maybe not with all the same degree of technology, but the concept, right, is that we treat the family, we support the family. Something that we can do everywhere.
Yes, I certainly agree. First of all, I want to comment on how encouraging it is that so many countries are starting to see the changes and its government getting involved and initiating the changes. With the drug regulatory bodies, I think there is a lot of issue with funding, so with them involved, that's the key point of making changes. And with the treating family, it's absolutely interesting. And for Rare Disease Review, as a nonprofit organization, we are initiating Rare Together and hoping to mimic what's happening in Switzerland, although we are a student organization. But we're hoping to connect patients with other patients and also learn about their family's need with clinics and other resources. So certainly we hope to have more of that in our community. Coming to the next question, in your previous talk, The Promise and Challenges of Treating Rare Disease, you have mentioned the concept of through understanding and developing treatments for rare diseases, there is a huge implication in precision medicine, integration of care, and patient management. Could you elaborate a little bit more on that?
Yeah, well, thank you very much for bringing those together, because they are not necessarily, it's not intuitive, right, in terms of what we're talking about. People think of rare diseases and, these very small patient populations, these exotic conditions sometimes. And then we talk about precision medicine, we're thinking, somewhat differently, but absolutely the same thing. At the basis of most rare diseases, as you know, some 80%, right, are genetic. So we're looking for what is the genetic cause of that disease. And many of them are actually increasingly what we're finding, right? It's 80% of them affect very, very small patient populations, 1 in a million in many cases. So they're absolutely, very much very specialized genotypes. In cancers, let's say cardiovascular disease, but other diseases as well, though cancers has been at the forefront of it. What we're recognizing, of course, is that there are many genetic variations of the cancers, and it isn't necessarily genetic variations in terms of what causes the cancers. It could be, but genetic variations that can affect, right, how that cancer is actually manifests or how it can be treated. So most of those, and what we know most are things like breast cancer, right? So BRCA genes, etc., how those can actually influence, the progression of that disease. And so the more that we can identify that, the more we can provide a targeted treatment. And at the end of the day, some of these conditions actually have very, very small subpopulations. And the same challenges and benefits there in treating that subpopulation are what we find with rare diseases. We find out exactly kind of what the gene is that's causing it, or genetic variation. What does it do? How can we actually ameliorate, mitigate, or to actually change, that gene expression, right, in a way that can best benefit that very small population. But it means clinical trials are done with small groups. It means in many cases, we have to be very clear in terms of the diagnosis of it in order to decide who should be treated and who should not be treated. And we also will have, I think, much more costly therapies because they are coming in and benefiting very small populations. So at the end of the day, we're hoping that, quite frankly, we can target people, regardless of whether we want to call their condition a rare disease, because it is, in fact, in a different place in the gene, right, that we can isolate, or we call it a rare subtype of a more common disease, because these are rare variations that can influence how that disease is actually expressed and can be treated. So it's kind of the same thing, and we're all moving towards much more precise diagnosis and much more precise therapies, which means that more people can be much more accurately treated. And at the end of the day, as we're talking about some of these gene therapies, right, hopefully get cured. So now that I can really target in on what your gene is and what that's doing, and I can fix that, whether you no longer have disease progression and no longer have symptoms, or you absolutely are able to stop that disease and to reverse that disease, it kind of comes to the same thing. So it's exciting. I mean, the way ahead. A lot of this has been pioneered in the rare diseases, but we're seeing more and more, right? Those same kinds of diagnostic tools, those same kinds of treatment developments, and that same kind of ability to make them available, kind of going into the more common diseases. So I think, quite interestingly, I think we're going to see a really rapid uptick. The trajectory of those diseases, of those treatments, are going to really skyrocket because we're learning so quickly one from the other.
That is very, very exciting. It seems like developing these tools, whether if it's for diagnosis or it's for treatments, it helping to develop tools to treat disease in general. There's a lot of overlapping, and of course, human body conditions is interconnected. So there is a relationship there. And from that amazing explanation, I expect the categorizing of disease be changing fundamentally, as you say, from being a rare disease and becoming a subtype of a condition. That's so exciting.
I mean, in cancer, as we know, a lot of these, genomic variations cut right across tumor sites, right? So we're not talking anymore about a breast cancer or prostate cancer or, a lung cancer. That genomic variation cuts across many kinds of different tumors. So that becomes the diagnosis, and it's not, localized to any specific part of the body. And what you're going to treat then is that genomic variation, which again, is going to force us to think about, what does this person actually have? They don't actually have breast cancer. They have this genomic variation. And the other thing it helps us understand is why sometimes when these, cancers metastasize, why they're going to where they are, right? Because that's where that genomic variation is going to be highly sensitive and able to, cause those genes to those cells to multiply. So, I think down the road we're going to quit talking about, kind of body part cancer. We're going to start talking about tumor-specific cancers.
Genetic specific cancers.
Yeah, exactly. It'd be kind of funny,
It's just more and more precise. It's so exciting. So much to look forward to. So, is there any other projects or research currently doing that you want to share?
One of the things that I belong to is the International Research Consortium on Rare Diseases. So it's the ability to bring in multiple stakeholders, multiple funders, multiple companies to actually work collaboratively on rare diseases. And if you look there, you get kind of a broad sense of, okay, where's this going, right? Some of the task force that we have there are looking at repurposing drugs. So what we're saying is that, only 5-6% of rare diseases actually have a treatment. A lot of those treatments that are going to come in for the others don't necessarily have to be developed from scratch. There are many treatments out there that could be repurposed to work for rare diseases. So we need to put the research into it. Obviously, it's understanding kind of what causes these, what other kinds of drugs are out there that could possibly address what it is you're finding. But and what's exciting about that, of course, is that it cuts the time to development so much more. So they're already maybe been proven in terms of it, sometimes in another disease, or at least they've already been developed to a certain stage. A lot of these drugs are sitting in vault that belong to mostly to pharmaceutical companies. It's getting them out, it's getting them into the research, which would be exciting. So repurposing drugs is really exciting. A couple of the other things that we're working on is really looking at, though, very different kinds of things. How do we actually engage, the family practices in terms of rare diseases? Totally different thing from common knowledge there. What's the role of telehealth in terms of rare diseases? And how do we develop, these kinds of models where you can have centers of excellence, but you're able to consult with and to treat patients that may be quite far away, especially for very rare conditions where you may only have a handful of specialists. What are the technologies that will allow us to connect these specialists to a patient that has the condition and to be able to help support and treat that patient regardless of where they are in the world? So some of the stuff we're looking at really is not just the technology, but for instance, one of the task force I sit in is looking at medical technologies for rare diseases. We oftentimes think drugs, but we don't necessarily think as much about the technologies either that are used in order to deliver the drug, so everything from these vectors, but also to other kinds of devices that can be used to either monitor or to provide input. So the area, and those are the areas as well that we need to encourage the development of. Unlike most rare drugs, orphan drugs, where you've got countries that have given incentives to develop those, there's very few incentives to develop the devices. And yet we know that these devices are going to become increasingly important. So there's lots of, I think, areas in which we're looking at. Some of it has to do with drug development. Some of it has to do with diagnosis. Some of it, as we recognize, rare diseases affect, as we said, a lot of different aspects. And the treatment and the care for rare diseases comes from all over. So we need to better understand the systems that could be in place to help us in terms of dealing with the rare diseases. I love the fact that, within this research consortium, we're working globally. So we're bringing in stakeholders from across the globe to actually work collectively and hopefully being able to take those solutions back to, wherever they are localized, or being able, and also collaborative approaches, learning from each other. So these are some of the things that are very exciting to me and keep me kind of moving forward.
Of course, it is very exciting. I am very, very excited just from hearing about that. From what you just said, I'm actually curious about what kind of devices that might be needed currently.
Well, monitoring devices are important. We talk, for instance, about the need for real-world evidence. So many of these drugs that come in and we're providing to people, we often provide them with not very long clinical trials because these may be very progressive severe diseases and you want to get patients to access. Oftentimes there are conditions in which there's no other treatment. So again, as opposed to having 2,000 patients in a 4 or 5 year trial, you want to make it so that you can do 2,000 patients, over 6 months and say, okay, do we learn that this is safe enough and that this is effective enough that we need to get them out to people who are waiting for these, therapies. We can't just, because in the meantime, they've got nothing and their disease progresses or they even die. So there's been good regulatory work to say, okay, what's the minimum amount that we can accept in terms of evidence to make the case that these could be available to a broader market. But it also means then that when they go onto the market, we have to monitor much more. And we can't monitor it as a clinical trial any longer, but we provide them 2 pages. So what are the ways in which we can monitor biomarkers? Are there devices? So in diabetes or in cardiovascular disease, right? There are devices that you can wear that monitor and measure your blood pressure, monitor your sugars, monitor your heart rate, those kinds of things. We need to develop more of those, and we need to get people engaged in order to be able to do that. Some of the medical technology that we're talking about, there are also technologies that allow us to, for instance, implant. If we're talking about infusion therapies, right? Can we do it in such a way that they can have a continuous infusion as opposed to coming in on a regular basis, slow continuous infusion, which would be better in terms of the patient and also less intrusive in terms of their lifestyle, right? Some of it is diagnosis, as we talked about in terms of genetic and the genomics of it. Can we do much better jobs? And this is kind of where genomics is getting cheaper, is that we're able to do a much better job of being able to identify not only where we need to be testing for those genes, but being able to scope it down. Huge technologies, obviously, in gene therapy. Everything from the vectors to CRISPR technology and gene replacement. Those are just exciting areas that we're going to have tremendous impact, and develop them more and more, putting more incentives in terms of looking at what are other inputs, what are other ways in which we can deliver the gene, other than some of the adenovirus vectors that we're using now that could have huge side effects. But there are other things that we can be doing. What are the other technologies that we can use in terms of harvesting cells, for instance, in order that we can actually modify them, and again, making those safer and more valuable. So some of the technology will be for patients themselves and to be able to have. Some of the technologies are actually in the actual treatment, and some of the technologies are going to be in the development area.
Thank you so much for answering my question. That certainly there's a lot to think about, and I will take my time to absorb that. But it was very educational. So we talked about a lot about in the global scale and government and policy scale. What do you think in terms of that? Some of the future strategies can be implemented to improve diagnosis, treatment, and understanding of the rare diseases?
Yeah, it's interesting because we look at all the exciting things that are here that we just talked about, right? So the question is, for us, the biggest challenge is how do we apply them to what we're starting to call the ultra rares? We kind of know how we can deal with the rares, things like the hemophilia, cystic fibrosis, muscular dystrophies, where there are sufficiently large populations that we've studied them. But the challenge we've got are really the ultra rare conditions where we may not even know anything about their natural history. As we identify a new disease, maybe through genomics, we may not know anything about, kind of what the future is for these patients because we've never had enough of them together to be able to identify them. So I think in many cases, the applications of what we're doing now are really into spaces which are going to be smaller in numbers, much more difficult and challenging to be able to find and to identify. So I don't know if there's a whole lot of, I can't even imagine what the new technologies are. I'm sure there will be many. I think our immediate challenge is how do we apply better what we see are these emerging technologies, and how do we make them work better? Gene therapy, for instance. Over and over and over, clinical trials are failing. They get to a certain point and then they don't work. And sometimes it's because they haven't got a vector that really works for the delivery of the gene. Sometimes what they want to do in taking out the cells in order to modify them are just too obtrusive, and the patient actually, is left highly immune compromised and doesn't recover. Sometimes we're not able to get a modification of the gene that's continuous. We know it's going to sustain, kind of continue. If we modify the gene, but maybe it has to, or we implant a replacement gene, right? But it's got to continue to perform. How do we know it's going to continue to perform over the period of time? So a lot of it really is going to be, how do we fine tune a lot of the technology that we've got now in order to make sure it works the way we want, works into the future, and can work across more diseases. So I'm seeing that as where the future is going to be, applying what we can and do know to more diseases, but also to those diseases that are harder to identify, harder to treat.
Yes, the effectiveness of treatment and the application of the current technology is absolutely the key to getting better results. As a graduate student myself, I would like to ask for people like me or others in the community, what can we do to help a rare disease community better at a more local level?
Well, what I would love to see is more people and groups like you guys. You're absolutely amazing in terms of what you're doing, the way in which you're spreading knowledge and information. You're translating, you should say, scientific information into much more accessible information for people. The way you speak and host, for instance, your forums to engage other students so that they are aware of this, and the way you're actually able to now want to work within the community to train. I think all of those are really important, and hopefully gives you, a really hands-on feeling for rare diseases and makes you want to say, okay, I really want to work in this area, and get you excited about it. That to me is kind of where we need to go. We need to do more of what what you're doing and being able to spread further. And, I would love to see in every, university across this country, but many other countries, units like yours, and where you're networked with each other and where you're able to be, kind of that kind of a program. We know that there are many that exist, in almost in isolation. McGill has something, University of Alberta has something, we have many things in the US. The question is, is there a possibility? We have worked better as a Rare Disease International by networking. Is there an ability for you guys to actually develop that network? I think you would absolutely be able to, exceed and to be able to do so much more as a network. It's a little challenging, right? Because you are students, and therefore, one, you're doing other things in your study, but also it's going to be a continuous changeover. But I think it's entirely possible once the infrastructure is there, once you have a program there. So that to me would be my encouragement to you folks. Bring others together with you and see what you can do in terms of being able to kind of network, learn from each other, and be able to develop, into a global community yourself.
Thank you so much for your kind words. Certainly, I would try harder to network. Yes, when I first started volunteering for Rare Disease Review, I learned so much. I continue to learn. So I appreciate you sharing so much valuable information today. As I learn, I care about rare disease communities so much more. And that's why I started the podcast. So I'm very excited to be a part of this. And I'm so happy to just to do as much as I can to help. And thank you so much for your contribution as well.
Well, let us know how we can help you as well, because and one of the things maybe, next week I'm going to the World Orphan Drug Congress in Boston. It would be lovely to have students there. They've set up a process for patients to be there. We're going to the International Research Consortium next year in Berlin. It would be great for us to have students there, who are able to kind of learn from and to actually be able to hopefully gain some more interest in it. So we need to think on our side, how do we actually provide more opportunities, not just for trainees that are already, kind of in the area and are maybe already, kind of part of some programs, but maybe, as you say, to graduate students, even undergraduate students who have a real interest in this area. So we need to excite you guys more and give you a taste of what possibilities are.
That's wonderful. I'm sure anyone would be excited to have this opportunity to learn. I myself would definitely be. And please keep us updated if there's any opportunities like that. I really appreciate it.
Well, we will create some. Let's do that. We'll make a commitment. We'll create some opportunities. How's that?
Yeah, that sounds absolutely great. I will keep in touch. So okay. I know you're busy. So
yeah, I thank you very much for taking the time to speak to me and to giving me the opportunity to share kind of what we're learning and what we're doing with your community. And certainly anybody that has an interest and wants to reach back out to CORD, happy to share our contact information and have them get involved with us.
Sounds great. The pleasure is ours for sure. Thank you so much for your time.
Bye-bye.